Hello and welcome to this webinar on advancing chronic kidney disease awareness and management solutions, which is hosted by Acacium. My name is Dr. Chris Lawrence. I'm a consultant nephrologist. I'm the clinical lead for nephrology for Xyla, which is a part of Acacium Group. If you aren't yet familiar with Acacium, Acacium is a global healthcare solutions partner, and Xyla provides an integrated comprehensive healthcare solution. Xyla is the leading provider in patient flow and elective recovery services, and Xyla delivers services in over 55 local authorities, NHS trusts, and integrated care boards. I'm delighted to chair this webinar today on this incredibly important and topical subject, and I'm so pleased to be joined by consultant nephrologist Dr. Andrew Frankel and Dr. Nick Sangala, as well as Laurie Cuthbert, Director of Fundraising, Marketing and Communications at Kidney Care UK. It will be apparent to everyone involved in kidney care that there are significant challenges in providing the service. Because of the nature of chronic kidney disease, we have an ever-growing clinic population with a very low new to follow-up ratio. As a result, presumably for demand management reasons, the current guidance for referral from primary care to secondary care requires really remarkably advanced renal dysfunction and very high risk of rapid progression towards kidney failure and the requirement for renal replacement therapy. My inescapable conclusion is that this doesn't just risk, it is shutting the stable door after the horse has bolted. It risks being a hackneyed cliche, but renal replacement therapy, by which I mean dialysis and transplantation, is just the glaringly obvious tip of the iceberg. What is not usually appreciated are the invisible sequelae of renal impairment, and most strikingly, the hugely increased risk of cardiovascular disease. There is thankfully increasing awareness of the importance of chronic kidney disease, and just in the last few years alone, there's been a seismic change in the therapeutic options available to reduce and delay the progression of chronic kidney disease. Until recently, management of chronic kidney disease was restricted to some fairly straightforward objectives, stemming from trials such as the UK prospective diabetes study, which first reported in 1983, namely control the blood pressure and control the diabetes better. And until recently, we didn't have much more to offer. Arguably, this all changed in 2020 with the publication of the DAPA CKD study. This and other studies showed that in addition to maximum angiotensin blockade, SGLT2 inhibitors reduced renal endpoints by nearly 40%, which is an incredible number. The advent of SGLT2 inhibitors, even for non-diabetics with chronic kidney disease, has been followed by the adoption of glucagon-like peptide-1 receptor agonists and non-steroidal mineralocorticoid receptor antagonists, all of which improve outcomes, but require that we identify patients who could benefit from these agents early. Chronic kidney disease, however, is by and large asymptomatic. So how do we identify people with CKD who would benefit from interventions? Too often, we don't. That the status quo is not fit for purpose is shown by one stark statistic. It is still the case, according to the latest report of the UK Renal Registry, that 20% of people who start dialysis do so less than 3 months from being referred to a kidney clinic. 30% of people who start dialysis do so within a year of first seeing the hospital renal team. Starting dialysis in an unheralded fashion is incredibly bad for you. It's psychologically traumatic. It's associated with increased lengths of stay in hospital, increased morbidity and mortality, and importantly, it removes patient choice over both dialysis modality and preemptive transplantation. When NICE last looked at the issue of chronic kidney disease, a screening program was not recommended, but this was because it was deemed that there was not a significant enough intervention that would result from early identification of CKD. That has now changed, and it's highly likely that the state of renal care and the armoury of effective treatments will now force a rethink. And in my opinion, it is highly likely that a screening programme for CKD will be adopted, particularly for patients at higher risk for CKD in the first instance. Recent work from Kidney Research UK suggests that without intervention to identify and intervene upon chronic kidney disease, we are facing an unmanageable and unaffordable burden of kidney disease. This raises the question of how an overwhelmed primary care or public health system will take on an additional screening programme, and of course how the equally strained secondary care clinics will cope with an enormous influx of newly identified patients. I know from personal experience in the kidney clinic that patients are already waiting too long to be seen and their follow-up appointments are overdue. And those are just the patients we know about. For the sake of all stakeholders, but particularly for patients, we need to examine how we can change the delivery of kidney care in the UK. That's quite enough from me for the moment. It's time to hear from our distinguished panel. Please do use the Q&A function to put questions to the panel. It gives me great pleasure to introduce Dr. Andrew Frankel, consultant nephrologist at Imperial College Healthcare NHS Trust. Andrew has extensive experience in managing people with kidney disease and has had a long-standing interest in diabetic kidney disease long before it became fashionable. And so we've invited him to share his real-world experience and his insights into the challenges for healthcare providers and patients. Andrew.
So, Chris, thank you very much for this opportunity. Thank Acacium as well for giving me the opportunity to speak to you all today. This is, as you highlighted, a really significant challenge for the healthcare system, chronic kidney disease, and is now recognised to be a challenge. We have big problems, and you've highlighted some of those big problems. You've also highlighted that we have fantastic opportunities now that we never had 5 to 10 years ago. We can really change the course of chronic kidney disease if we can get the treatments to the patients and to the right patients, and we can get patients to understand what they're for, so they actually take the medications. And I think it is important I do reiterate a couple of the big fundamental issues that we have. The first one, which I think you alluded to, is very much in our hands and our responsibility, Chris. I know not you personally, but you, me, and Nick. We've all been part of the nephrological world. And I think you pointed out that we created a situation where referral criteria that are used by primary care, essentially, if you look at the algorithms, they look very complicated. But if you actually interpret them, they mean, please don't send me this patient unless it is something I'm interested in, or unless the patient has reached a point where we have to prepare them for end-stage kidney failure. Now, I know that's one way of looking at this, but what I would say, there is a problem with this in that it has created an implicit and false view in primary care that GFRs above 45 or, not referral level aren't a serious disease. And one key message I want to get across to everyone: you take someone with 10 years history of diabetes, a GFR of 58, a bit of albuminuria, and you did a kidney biopsy on that individual, you will find they already have significant damage on the histology. And we have got to change the whole dialogue and the whole perception so that people understand that the damage has been occurring for many years and that we need to intervene. And indeed, we have now the weapons to intervene with to reverse this, and we need to be doing this earlier. And I know that the government, it's not just the new government, I think the previous government were looking at this as well, want to change the whole dialogue from a treat and firefight service to a prevention service. And we need to think about how we can do that. We also need to understand that most of these people are sitting in primary care. Primary care is working hard, and they do have a lot of strain. We therefore have a duty, I think, to think about how can we deliver better care for people with early CKD as efficiently and effectively as possible, and ensure that we pick up the people who tend to fall through the cracks. And I would say to you that actually it's not as difficult as we think, because although you talked about the screening program, Chris, I would highlight to you that NICE did delineate a group of people who should be screened for CKD. People with diabetes, people with hypertension, people with cardiovascular disease, as well as about 4 or 5 other groups. But if you take those first 3 groups, you pick up 90 to 95% of people with CKD early. And the secret is to knit the CKD care into the care pathways of people with diabetes and hypertension, because it is a cardiorenal disorder, cardiorenal metabolic disorder. And that's what we've got to start to do. So rather than just give you lots of problems, let me just tell you very briefly that in Northwest London, we have been working with primary care for the last 10 years and have done a number of projects to try and improve the integration, to get nephrologists to move out of their comfort zone, move into primary care and support primary care. It doesn't mean we have to see every patient, it's to provide that support. And we've recently undertaken a piece of work to look at technical aspects of how we can support primary care in managing this. We have introduced within our primary care systems dashboards and searches that allow for easy identification of people who are either unscreened, uncoded, or not optimized. Direct links from GP systems into our secondary care CKD education program. And streamlining all the current clinical practice proformas so they take a cardiorenal metabolic approach. So in the for the hypertension proforma, there is a CKD section, and similarly for diabetes. And these are just the first technical steps that we've taken in Northwest London. Huge amount still to do. How do we get people to actually use this and use this technology? And how do we ensure this technology isn't just picking up the easy to reach patients? So lots of problems, lots of solutions potentially, and we just need to get these to the patients. Chris.
Thank you very much, Andrew. I had a quick question arising from that, if we can go to that. In Northwest London, are the primary care IT systems all on one system, or does your approach work no matter who their IT providers are?
So, no, so we work with System 1 and EMIS. So we have a mixed economy. And we have to do everything in duplicate, but our integrated care system and our business managers and IT leads work with us. And we have the same opportunities in both systems. So we built them in both systems because you have to have them on the GP system. They can't, I mean, there's a lot of, standalone systems are fine, but when you're sitting there in primary care, you've got the patient in front of you, you want to use that single system.
Thank you very much, Andrew. I'm now going to turn to Dr. Nick Sangala. Nick is a consultant nephrologist in Portsmouth and is also the co-founder of My Renal Care. And I'm going to ask Nick to share his experience of using a digital health solution to resolve some of the challenges that we've faced, particularly from the perspective of the nephrology clinic.
Thank you, Chris. Thank you, Casium, for having me here. It's a pleasure, and thank you to all of those who've taken time to join the webinar. So my name's Nick Sangala. I'm a consultant down at the Wessex Kidney Centre. And I just wanted to start by highlighting the size of the problem that we're facing down here in Portsmouth and Wessex so that we can ram home the need for change. So we have a catchment area of just over 2 million population down here. And Kidney Research UK estimate that around 220,000 individuals in my region suffer with CKD. Of that 220,000, about 90,000 have stages 3 to 5. My renal unit is large. We have about 23 consultants. We care for 15,000 patients with CKD. That means there's 75,000 patients on my patch walking around with stage 3 to 5 CKD. This is a capacity issue. I feel very much it's a renal capacity issue. I understand the burden our GPs are under. I don't think it's fair or realistic to pass that burden on. And I accept it is a colossal challenge, and change is needed. So one way that we're addressing that down here in Portsmouth is by using digital health, specifically My Renal Care. And so I thought I'd give you a little bit of a background behind our solution. And it goes back to a patient of mine who, funnily enough, was also called Nick. I would see Nick 3 to 4 times a year. He worked for Network Rail. He would take time off work to come and see me. He would drive about 30 minutes, pay for parking, and spend 15 minutes with me. And on a day back in 2018, I walked to my waiting room, which is about 30 seconds from my office. And on our way back to my office, he hands me a piece of paper. And on that paper is a list of blood pressure readings that he had taken once a week ever since our last meeting. And they were fantastic. I looked at him and I said, "Have you seen your blood results?" And he kind of smiled and winked. He said, "Yeah, they're amazing, aren't they?" And I said, "Well, yeah, they are." So by the time we'd reached our office, and I sat down, we looked at each other and kind of simultaneously realized that we'd done all we needed to do. And his literal words to me that day was, is that it? So I asked him about his dog, and we had a little bit of a chuckle. And I promised him, but by the time of his next appointment, that we'd better do this digitally. Now, that was in 2018. And at that time, my clinic capacity was running about 105%. The wait time for me to see a new appointment or a new patient was 4 to 6 months. And I looked back at the activity of our whole unit and found out that between 80 and 85% of our outpatient appointments were for patients like Nick. So those of you on this call who do this, I want you to think about the patients you see and what proportion of them are like Nick. So what does My Renal Care do, and how does My Renal Care address this problem? My Renal Care replaces these just-in-case, regular, routine face-to-face appointments with remote and digital care. So our patients, like Nick, are building an electronic health record at home on My Renal Care. They're monitoring their blood pressure, their weight, their symptoms. Some of my patients are dipping their urine. They have a calendar on My Renal Care that notifies them when they're due an appointment, a virtual appointment with me or another clinician. They get a reminder to go off and have a blood test. That blood test can be done at their GP practice or the local hospital, and the results are all amalgamated on My Renal Care, which means at the time of my review, I can get onto My Renal Care. I can see how my patient is doing. I've got plenty of data points to make a judgment. I can see the blood results, and I can message them without need for them to take time off work for a phone call or to come and see me or a video call. It's important to highlight that they're not just left in the digital ether. They have direct access to me if things should deteriorate between these time periods, something that is now called PIFU. So this is a really empowering way of caring for patients. Patients feel empowered. They're self-monitoring themselves at home against personalized targets. Chris mentioned the personalization of health. My patients know what targets they have been set, and they've been set by the doctor that knows them. So the targets for a young membranous patient are slightly different to an elderly patient with diabetes. They have access to educational content so that they can understand why it's important for them to take their medication and track their blood pressure and improve their glucose. They can see their results, and of course they can contact me directly. So truly empowering for patients. It's more convenient for patients, less travel, less disruption, and therefore less costly for patients. And most importantly, it is appreciated by patients. Our patients like this service. An example of this is just yesterday when I saw a patient who I'd been looking after remotely for a good 2 or 3 years. I arranged to see him face to face. I went along to the same waiting room I described earlier, and he looked at me, he said hello, and he kind of looked a little bit confused and said, "Well, what are you doing? Why am I here?" And I mean, I didn't have a really good answer for him. My answer was, "Well, I thought you might want to see me." And so we ended up having a chuckle. We had a nice chat, but basically agreed that I'd wasted his time. And so we're off back to remote monitoring. Now, it is really warming, the feedback that we're getting from our patients of all ages and all stages of kidney disease. Our youngest patient is 18, our oldest is 93. 94% report feeling well looked after. 89% prefer this way of working to the standard face-to-face or phone call. And 93 would recommend My Renal Care to other patients. For clinicians like me, it makes me more effective and more efficient. Not only is this because of the virtual care that I can deliver on the platform, which is far more efficient, takes around 5 minutes as opposed to 15 minutes, but it means I can communicate with my patients. I can answer their concerns directly. And of course, I've got access to a huge amount of data, so I can make data-driven decisions compared to the decisions that we were making in one-off 3 times a year or 4 times a year appointments. What about the impact My Renal Care has had on our service? So this was looked at by an independent health economist back in 2022-23. they found that My Renal Care increased capacity by 30% whilst reducing cost by 25%. So those are numbers, they sound great, but what does that mean for me? My wait time has gone from 4 to 6 months to literally a week. We have managed to deliver 3,000 virtual appointments on My Renal Care, saving the amount of time that it would take to deliver 1,000 new patient appointments. And what's really exciting is this is just the start, and the potential is bigger. So what is the blue sky thinking here? What is the potential for this novel way of working using tech integrated with clinical medicine? And I want you to bear with me here, and I want you to imagine a world where this is scaled, and imagine the impact on your unit, on your unit's waiting times of having all your stable patients with CKD managed digitally and remotely. And remember, for my region, that's about 80% of all our outpatient activity. I want you to imagine the impact of moving all your entire backlog of follow-up appointments onto a solution like My Renal Care with a dedicated team of specialists who are there to care for those people remotely and digitally, so that you in your unit only see the individuals that you need to see and that need to see you when you need to see them. And the exciting bit about today is this isn't a world you really have to imagine. This is the offering that Xyla is proposing and has created. Your patients managed by a team of specialists remotely. Xyla can deliver thousands of follow-up patients efficiently and effectively, and our experience shows that it can be delivered in an acceptable way to patients. And just imagine for a moment what that would mean for your unit, and imagine what would that mean for our ability as a community to really tackle the growing challenge of kidney disease. So I don't know about your unit, but I do know in Portsmouth, this will allow us to start making a dent into those 75,000 people who at present aren't being seen by a specialist, and perhaps go beyond to reach the patients that both Andrew and Chris have talked about with earlier stage CKD. And that's a thought that I want to leave you with really here, a vision, the potential impact of a solution like this could have on CKD in your region and nationally. Thank you, Chris.
Thank you very much, Nick. Just forgive me if you mentioned this and I missed it, but in terms of recruiting patients onto My Renal Care, do you always see patients face-to-face for their new appointment? And then what sort of onboarding process and training is there required for patients?
Absolutely. So all my patients, all my new patients I see face-to-face. Establish a relationship, invite them to use it. Some of our patients have already seen and heard about My Renal Care, and they can sign up. And then what I personally tend to do is ask them to start using it as a way of tracking the observations that I talked about, and I'll perhaps see them one more time thereafter. At which point they've already started recording key information, and when I see them in my follow-up clinic, we start talking through what they've recorded, how their blood pressure's changed, what the symptoms are, and then if they're comfortable, we move on to remote. And it's not a situation where once patient is remote, they're always remote. They're remote for as long as they wish to stay remote and things are stable. So if they record or find issues, as my patients do, and this is the engaged patients, I now have patients reaching out to me, telling me their blood pressure is not controlled, or their general practitioner or another medic has changed their medication, or their legs are swelling up, or any of these issues, then I now have capacity to see them next week. So there is definitely a personalized aspect of this. I think it's important that we establish a rapport face-to-face in the first instance, and then move forward in a way that suits that patient. And it's not one size fits all. So if I was to give you a rundown of my population of patients, I have some patients that are 90% remote, like the chap who came yesterday who wondered why I'd seen him. And I have patients who I see 50-50. And it depends on the individual and their stage of CKD and what's the problem and what's happening at the time. So it's very personalized and very adaptable to the situation.
Thank you, Nick. And remind me, what proportion of your patients uptake the offer of the digital platform?
So that varies from consultant to consultant. I'm running at about 80%. The other earlier Dr. Lewis is running slightly less than that, I think. and other members of our team are slowly growing. So as I say, we've got about 10 to 15,000 patients with CKD. We have about 2,000 patients using My Renal Care at present, and it's growing at about 50 a month.
And of the users you mentioned there in your user feedback, 93% would recommend it. Of the 7% who wouldn't recommend it, what are the reasons that people don't choose to recommend it?
That was very interesting. So when we looked at the reasons, they were firstly, there weren't that many, and they were kind of wide. So, you know, some were technical. I mean, some people basically said they didn't like the look of the website, and other people had a negative experience. But like I said, the vast majority had a positive experience and would recommend it. And that experience, you know, this isn't replacing healthcare with a digital tool. It's using a digital tool to help build relationships and manage patients. So some people had an issue with the tech, and some people had issues with the way it was being used.
Fantastic. We've got some great interaction from the Q&A here. There's a question here. Perhaps you could tell us how My Renal Care differs from Patient Knows Best.
Yeah, that's a great question. We get that all the time. In fact, Patient Knows Best is a partner of ours because they themselves recognize that we deliver two different things. Patient Knows Best is a solution that allows patients to see their results, but it doesn't necessarily allow for this engagement that we have purposely built My Renal Care for. So My Renal Care was purpose built to enhance this communication between clinician and patients. It was built with patients and with clinicians. So we deliver workflows for the clinical team and give patients the ability to track every aspect of their care. So from early CKD to every modality of transplantation. So our home dialysis patients use it. Our peritoneal dialysis patients use it. It has renal specific prompts built in. And the novel thing is this direct communication that which is you know, known as PIFU, which is all centered around enhancing that experience for patients. So the reason we work with PKB and we don't see each other as competitors, as they share information with us and allow us to deliver this solution that is used within the healthcare setting and patients.
You're getting a lot of interest and praise for the approach that you've taken in the questions here. Somebody's commented that this is fantastic for saving time, money. It's great for the environment, removing the need to drive your car to the hospital every time. And a comment that it's very useful for patients, specifically those that are younger and middle-aged. But that brings me to a question of how do your older patients find it, and how do you make sure that the platform delivers on equality of access for all of our patients?
Yeah, so that's two things. The first thing about age, honestly, this is an assumption that everyone makes about age, younger people using it and more elderly not. This isn't our experience. So we have young individuals who do not engage with digital, and we have elderly patients who do and do regularly. And some of my most consistent users are older than the others. So I don't think it's right to kind of paint everyone with that same brush that young will use tech and old won't. We don't find that. And of course, people get help from, you know, people who struggle can get help from their relatives to do this. Addressing the issue about inequality. Look, this is a really, really valid question, and we're often asked about whether digital can exacerbate inequality. And I'm afraid I don't have the answer for you just yet. What I will say is what we do know is the current situation is driving inequality. Currently, patients need to take time off work, travel to see their doctor, and some simply can't afford to do this. I heard from Kate Vinan yesterday about the educational content of literature that we give to patients. 61% of English working age population do not routinely understand health information. My view on this is digital can deliver more accessible information for patients. I think digital can make healthcare for individuals more accessible. I do think more work is needed on this. to make sure that we don't exacerbate inequality. And I think it's important, therefore, that we recognize that it could do that. And when introducing solutions like this, we do all that we can to mitigate against that eventuality, whilst recognizing that it can be a solution. Now, one thing I will say is, and this sounds a little bit conflicting, that what My Renal Care has done for me is it means that those who can use it are enabling me to see those who can't. So my clinic capacity is huge. I said I was running at about 105%. I'm now running at about 70%. So if you're someone who I need to see regularly who can't use the platform, prior, that would be difficult. Now I've got the capacity. So it's a valid point. We have to take it seriously, and we'll do all that we can to mitigate it. I think that's the right approach.
Thank you, Nick. Questions are coming in thick and fast, but I'm going to roll one more question into two, and two more questions into one, and then we're going to move on to our final speaker and come back to questions at the end as we have time. The final question was about how My Renal Care integrates with primary care systems such as Epic and MyChart, and also the second question, which is similar but different, is that from the primary care point of view, coding can be a bit of a challenge in, for instance, EMIS. Do you think that can assist with coding and thereby call and recall integrated into the same platform? I don't know if Andrew perhaps has a view on the last part of the question.
I'll do that very quickly, and Andrew can jump in if he wants. But firstly, integration is a simple, it's technically simple. It's easy to do. We have not had a need to integrate with System 1 and EMIS at present, but we're working towards that because we recognize that is the future. The future has to be an integrated system. And so our pipeline will be integration with all three major systems that GPs use. In terms of coding, look, you're absolutely right. I'm not a fan of duplication of work. If we had hours, we could talk about my vision for the future, but that vision would include an integrated way of having us identify patients with CKD and have the coding done our side, pushed into GPs as opposed to the other way around. It's all doable. I'll hand over to Andrew if he's got a comment there.
Yeah, well, not much to add. As you know, I'm very envious of the fact that you've got My Renal Care in your region and we don't have it in ours. Our solution in Northwest London 10 years ago was to move many of our stable patients into primary care. We still, however, need to find a way as an integrated system. That's not saying it's primary care's or secondary care's responsibility, an integrated way that we can still monitor and provide support for those individuals with earlier stage or stable CKD. And I'm very interested to hear, and will be interested to hear, how you do integrate My Renal Care into primary care systems in the future, and whether or not you can integrate it across disciplines. We better remember, many of these people are also going to diabetes clinics or being assessed for high blood pressure. And if there's a way we can integrate the whole thing, that would be brilliant. In regard to coding, our advice about coding is, yes, it's a real faff, and we've got to make it as pragmatic as possible. Remember, coding provides a public health information. Nobody changes colour as they go from CKD 3A to 3B. It's a public health tool, and it ensures that you recall the patients, you're more likely to recall the patients more frequently. So anything that helps with coding, that says automatically tells the GP, and we've tried to do this with our blood results in Northwest London, all of the GFRs in Northwest London come back with a suggestion of CKD code, if it is CKD. So that you get some automation around coding. To me, it's more important that patients have a code rather than, it doesn't bother me whether it's CKD 3A A2 or CKD 3B A3. That doesn't matter as long as you are recalling the patients and they know they have CKD.
Thank you very much, Andrew. And now I would like to move on and introduce Laurie Cuthbert, who's been waiting very patiently and uncharacteristically quietly. Laurie is Director of Fundraising, Marketing and Communications at Kidney Care UK and has a personal and professional mission in healthcare with over a decade's experience in the third sector. He's particularly focused on patient advocacy and patient empowerment. So I'm delighted to ask him to bring his perspective to this conversation. Thank you, Laurie.
Thank you, Chris, and thank you ever so much for having me this afternoon. It's a real pleasure, and I want to focus on a couple of the points that have already been raised very eloquently by Andrew and Nick. And Nick, I'm glad that you mentioned literacy. I think health literacy or health illiteracy is talked about very frequently now across the UK, and I'd like to start by talking about a statistic that was published a few years ago by the OECD that found that England is the only country in the developed world where literacy is worse in the younger generation than those approaching retirement. The only country in the developed world. So when we then consider health literacy, this really comes down to choice and agency. If you do not understand something, if you do not understand the condition that you've been diagnosed with, or if you've been to see your primary care physician and you've been told not to worry about your kidney function, we don't worry about that until a little bit later. It's very likely that you will not think about that again. Sadly, it is the case that many kidney patients feel like they're on the scrap heap. They've either been told too late that their kidneys are failing and therefore have become something of a passive recipient of their care, and that has a myriad of different effects on their quality of life. You can imagine being told with very short notice that you are going to need to start dialysis. It is then incredibly difficult for you as a patient to access the services that will improve or help you to deal with that diagnosis. That might be accessing a blue badge. That might be accessing benefits because you're unable to work any longer. And of course, you will all have heard, I'm sure at some point, a kidney patient say that they've been told that they don't look ill. And all of those different factors add up to an experience that is less positive and less constructive than it should be. And I'm going to give you an example to really bring that to light to you, because for me, this is really about the opportunity that we have in front of us. No one wants to just point the finger and say things are terrible. We know that this is not an intractable problem. And you've already heard today about some of the fantastic solutions that have been developed that will allow us to improve that patient experience and improve their ability to make choices that are right for them. We were approached a couple of years ago as a charity by the Welsh Kidney Network. And we were approached at the onset of the cost of living crisis, so still in the middle of the pandemic. And we were told that many of their dialysis patients had simply stopped going for treatment because they were so worried about their ability to put food on the table, to eat the right food, to help maintain what function they did have. And that was causing huge challenges. Adherence to one's care program is absolutely critical, as we know. But if a patient feels that they are juggling lots of other aspects of their life simply to be well, it's incredibly difficult for them to adhere to that. As a result of that, we were able to develop an in-person welfare and well-being service to alleviate some of those pressures and actually to allow the healthcare professionals caring for them to focus on caring for them, improving their quality of life, improving their care. And that might be as simple as giving somebody a counselling session. Now, without those solutions and with some of the cuts to statutory funding, it's even more important that we look at creative and lateral solutions to enable patients to get the treatment that they deserve in a consistent way. And I think we'd all agree that there is huge variation at present in the system. It is sadly the case that one can drive from a trust to another trust and likely have quite a different experience. And that is simply not acceptable. And we see the sharp end of it as a charity, with so many patients coming to us to either say they were diagnosed too late and they didn't really understand the role of the kidneys, or even worse, that they've been told at an earlier stage that there was nothing to worry about. We know that if we can arm and empower patients with the ability to make those informed decisions and with the development of new therapy areas to maintain the kidney function they do have, the outcomes for that community will be far greater. However, it is the case that if you look at different areas of the country at the moment, that there is a disproportionately high level of disadvantage for the kidney community. In Nick's area in Portsmouth, if you just look at the dialysis population, more than 50% of that patient community live in the most deprived quintiles. And that means that their health literacy, their lifestyle choices are likely to be dramatically affected. It may be more expensive for them to eat the food that will enable them to make sure that they are having the best experience and they can adhere to their care. And that picture, sadly, is played out across the country. And I think we often make an assumption that health literacy is something that's insurmountable. Or that in fact that digital solutions are off limits. And I'll give you an example to refute that. We've recently launched our Bloody Amazing Kidneys campaign, and we had a hope that in the first month we would get around 11,000 members of the general public to take a quick digital kidney health check. In the space of that month, we've had 111,000 people take a kidney health check online on our website. More than 60% of those people, around 60,000, were over 60. And we can see from some of the geographical data that many of the people who have taken a test, there's a particularly high proportion in North Norfolk, which happens to have one of the highest rates of disadvantage in the country. We know that in that part of England, there is very high prevalence of cardiovascular disease, type 2 diabetes. And so what is next? It is digital solutions. It's joining a system up so that patients can access a consistent level of care that's right for them, to enable you as healthcare professionals to focus on what's most important in terms of their care. And I think we've all heard today that there's great work happening. And if we can find a way to join all of that up, I think Andrew's metaphor is how do we knit all of those things together? We've seen that when it does work, it has a dramatic impact on quality of life for patients. Chris, I've been speaking for a long time and I get sick of my own voice, so I'll kindly pass back to you.
Thank you, Laurie. That's fantastic. I know that Nick's been addressing some of the questions in the chat, and the questions are still coming. A couple of questions to go back to Andrew, perhaps. What do you think the role? What does a gold standard screening program for CKD look like? What do you think we should be providing?
As it is now, I think it is, first of all, one of the things I would say about the screening program is we're trying to get across the concept, not of blood tests for GFR, urine for albumin, but of a kidney health check. If we can start using the terminology kidney health check, I think it's easier for people to understand what that means. So if you can automatically ensure that written into your management plans for people with diabetes, people with hypertension, and people who've got any form of ischemic heart disease, that they have a kidney health check at the appropriate interval, you will screen successfully the vast majority of people with CKD that you have on your books. It doesn't cover the whole group, but it covers a significant amount. So for me, it's about, one, identifying the cohorts on your system, two, integrating the screening with other reasons why they may be attending or require assistance in primary care, so we're not coming up two separate appointments, and three, using language that people understand so they know why it's important for them. So those are the three key ingredients for me.
Thank you, Andrew. I don't know if anybody else has the same problem that I have, that you need to send 3 urine samples for one result, because the first one goes in the wrong bottle, the second one leaks or is unlabeled, and the third one might be right. Because I think there is a predilection towards sending urine culture in primary care, which obviously is in a different bottle to the urine albumin creatinine ratio. But it's my minor cross to bear where I work. Nick, what's the role of the CNS in the digital platform?
Yeah, great question. And you know, I suppose you wouldn't be surprised to hear that I think there is an absolute role here. I think certainly the earlier you get when so early stage CKD, if you identify people early, then there's basically a protocolized plan to optimization that requires a few checks. It requires a blood pressure check, but it's something that can be passed certainly to the CNSs that we have in our renal unit. And I would go so far as to say, I mean, we have a wonderful team of specialist nurses down in Portsmouth, managing our advanced kidney patients. And I think what I would suggest is it's a way to move stable patients or early patients who need to be optimizing out of the hands of the consultants, who can then spend more of their time seeing new patients and putting them on a path, or dealing with complex, difficult patients who need to be seen face to face. And I think that would be a way of absorbing the growth that we have. You know, when I joined Portsmouth Hospital back in 2009, I think there were 7 consultants. Like I said, we're at 23 now. That's 1 a year. And I think there's aspects of what we do that we need to do, and that probably needs to be done face to face. And there are aspects of it that can be shared with CNSs, so long as we do what everyone has talked about here, which is make sure the patient comes first, make sure it's personalized, and therefore make sure we allow patients to optimize their own health outcomes. I think there's an absolute role there for specialist nurses and other allied health professionals, definitely.
Thank you, Nick. And Laurie, I think there's a lot we can do, and there is a lot to do. It's not going to be a job that's done overnight, and it's not a quick fix. But if you could pick one area to focus on first of all that you think would be most impactful for improving patient care across the UK, where would you start?
Yeah, no, thanks, Chris. And my goodness, that is a vast, loaded question. I think you go where the data is. So, you know, I mentioned North Norfolk, and that's just one example, but I think you really must look at the risk factors. And if you wanted to do a proactive or preemptive screening, one of the things that, in fact, Nick and I have been speaking about for quite a while now is it is your classic have a mobile screening option in a supermarket car park. For instance, you could use community pharmacy to do the same, as they often will do. Vaccinations, could you be testing for high blood pressure? But I think we need to raise that general level of awareness in the general population. You know, we've done a lot of work to survey patients with a diagnosis as to ask them, you know, what do you wish would have happened before you'd been diagnosed? And almost universally, the answer is, I wish I'd been told about the importance of my kidneys. I wish I knew what they did. I wish I knew what symptoms to look out for. And yes, we know it's often asymptomatic, but, you know, noticing small changes in your body, you know, you suddenly might have swollen feet, for instance. So many people did not know that we hear from. And then, of course, that's compounded if you do go and see your GP and you're told there's nothing to worry about. So for me, it is about standardizing and making consistent that proactive screening. That could be done to start with, digitally, to identify those people who are at risk. And we've identified more than 60,000 people who are at higher risk based on those 4 risk factors. And then I think you need to go further and go to the people. We've seen the success of that with the British Heart Foundation, with the Macmillan model. So again, I come back to my original point. This is not an intractable problem, but it needs to start happening consistently. There's pockets of best practice already happening. And I think sometimes our exasperation is that that's not rolled out.
Thank you, Laurie. And there's an excellent point being made that kidney health is rarely in isolation, and focus ought to be on better care within the envelope of multiple long-term conditions. What does the panel feel of upskilling the wider workforce and making every encounter count, is the question. So, Laurie, starting with you.
Yeah, I missed the last part of that question, Chris. Sorry, could you repeat it?
Yes, it was. So it's about how this is. You know, I understand the point entirely, and I think the answer I would give is that actually the one thing that attracted me to nephrology is that it really is not just about the kidneys. We actually deal with every system in the patient, albeit they also have kidney disease. And we make ourselves sometimes unpopular by having an opinion that might differ from the cardiologists in terms of what the management ought to be or what stroke prevention ought to be, because we have a nuanced view based on the fact that the patient also has kidney problems. So the question is that because kidney disease is rarely in isolation, the focus ought to be on better care within the envelope of multiple long-term conditions they have. And the person asking the question would like to see better primary care rather than bringing these patients to renal services where we focus on kidneys. But I think we as a panel will all agree that we don't just focus on kidneys. It happens to be the thing that's brought them in front of us. But what does the panel feel about upskilling the wider workforce so that every encounter in primary care and with other secondary care physicians counts and can impact kidney risk?
I'm happy to have a stab at that. So I think I agree with the premise. Of course, as the questioner says, our patients often have lots of comorbidities. So I'm going to split it into two things. I think the first is upskilling primary care, and I think it was Laurie who mentioned follow the data. I have no issue with upskilling primary care. I don't necessarily agree that they necessarily need upskilling. I think primary care have a capacity issue. And when you look at the numbers that I share in my region, the idea that they're going to be able to take on that work, I think they perhaps have the skill to. I don't know whether they have the capacity to. The next thing I'll say is that in my experience, and I'm not going to talk for everybody, so I'd love to hear Andrew's thoughts on this as well. I think, Chris, you've already made it. Nephrologists tend to take an overview of our patients. Our patients are patients who happen to have kidney disease, and we're doing all our best to manage their kidney disease. And if they see their cardiologists, they don't normally establish a long-term relationship with them. So my experience is, yes, they might have other comorbidities, but the specialist input is often fleeting and when there is a crisis, whereas our patients are our patients until they're no longer our patients. And I think...
Nick, sorry to interrupt you. I'm just in the interest of time. I'm just going to stop you there because it's such a complex question, and we've had so many questions that we're coming towards the end of our time together. So if we haven't managed to get round to your questions, apologies. We will pick them up individually via email. I'm very grateful to the panelists for sharing their time, their expertise, and their obvious passion for the subject. And I'd like to just close by suggesting that we are at a threshold. The old-fashioned model of delivering kidney care is too little too late, and yet will still overwhelm the NHS. We have the opportunity to act now to try to avert a crisis in renal care, to deal with surging demand, capacity constraints, and an ageing population with an increasing burden of chronic conditions. Some of Lord Darcy's recent recommendations are particularly relevant to the discussion about how we can be more effective and more efficient in delivering care. We need to re-engage staff and empower patients, and we need to do that by focusing on fostering a healthcare environment where both staff and patients are empowered to improve kidney outcomes. We need to lock in the shift closer to home, moving care delivery closer to patients' homes, particularly for chronic conditions like kidney disease, which require such regular interactions with the healthcare system for monitoring and management. We need to drive productivity in hospitals, but we need to acknowledge that it's not a hospital-only problem. We need to explore strategies to enhance productivity throughout the whole system, and this can only be addressed with an integrated system-wide approach. And we need to tilt towards technology. Of course, Ara Darcy would recommend tilting towards technology. And we need to advocate for the adoption of technological solutions to support patient care, enhance efficiency, and reduce costs. And this fits, of course, with the Secretary of State's ambition to shift from a reactive to a proactive and preventative health service. And I very much hope that the recently reported uplift in NHS funding will be utilised to achieve some of the goals that we've discussed today. I hope that you've found this webinar both interesting and perhaps provocative. It remains only for me to thank you for your participation, your very active involvement in the question chat. Thank you. And to thank my distinguished colleagues for joining our panel discussion. If you would like to discuss with us how we can work together to deliver some of these solutions by providing clinical capacity to support delivery at scale, please do not hesitate to get in touch with us at Xyla. Thank you very much and have a very pleasant rest of your day.